In this late lecture, just before the lunch, I would like to focus on other causes of sudden cardiac death. Based on the experience we collect in the Veneto region of Italy. Since 1979, a prospective clinical pathologic study of all sudden death occurring in young people has been carried out in the northeastern Italy that has an overall population of 4.5 million, a young population 12-35 years undergoing usually pre-participation screening is 1.5 million, and young athletes 100,000. So according to the protocol of this prospective study, all sudden death victims were studied by the local pathologist, and the entire heart was forwarded to the University of Padua for a very detailed analysis according to a uniform morphologic protocol that include gross examination, microscopic examination of heart, histologic examination of the ordinary myocardium, and histologic examination of the specialized conduction tissue according to the technique of serial sections. So in the period 1979 to 1999, we collected 300 cases of sudden death in young people. That accounts for an incidence of 1 per 100,000 persons per year. And you can see here that the incidence was 1.5 in males per 100,000 persons per year, compared with 0.5 in females. Again, you can see here that the incidence was significantly higher in athletes, young people engaged in competitive sport activity, 2.3 compared with the non-athletic counterpart in our region. So in the multivariable model, you can see here that the most important independent predictor of sudden cardiovascular death in young people were, first of all, the male gender. In other words, sudden death in the young is a male problem. And the second point was the sport activity. Sport accounted for an increased risk of 2.5 in athletes compared with non-athletes. You can see here that sport activity in adolescents and young adults account for an increased risk of 2.5 times greater. So in other words, with regard to the all causes mortality, if you consider just cardiovascular causes mortality, the risk further increases to roughly 3. In other words, sport activity in this age range, 12-35 years, is associated with increased risk to die suddenly. What is important to realize is that not the sport in itself the cause of the increased mortality. Sports act just a trigger for ventricular fibrillation, cardiac arrest due to ventricular fibrillation in those athletes affected by cardiovascular disorder, specifically predisposing to ventricular arrhythmias, ventricular fibrillation, induced by catecholamines, but effort. You can see here the distribution of these cardiovascular causes we found in our experience in our population. You can see here that there were 8% of non-cardiac causes, such as cerebral or respiratory. 6% of sudden death remain unexplained, probably due to condition that predispose to ventricular fibrillation in the absence of structural abnormalities such as ion channel disorders. And you can see here that the most important causes were cardiomyopathies, followed by premature atherosclerosis and congenital coronary anomalies. You can see here that according to the concept of genetics versus non-genetics, you can see here that the non-genetic causes accounting for roughly 60% of fatalities in our population of young individuals. So what about comparison between athletes and non-athletes with regard to the different causes of sudden death? You know that arrhythmogenic right ventricular cardiomyopathy is the leading cause of sudden death in our region, but it's not the theme of my presentation today. So ARVCD is followed in our experience by premature coronary atherosclerosis, very important. And premature coronary atherosclerosis is more often found in athletes compared with the non-athletes. Congenital coronary anomalies also accounted for an increased mortality among athletes, and also mitral valve polyps, myocarditis, and conduction system diseases are significant causes. We will focus on this condition, non-genetic condition, responsible for sudden cardiac death. You can see here that premature coronary atherosclerosis is very similar to, in terms of prevalence, to cardiomyopathies. So it's a not so negligible cause of sudden death in this age group. We know that coronary atherosclerosis is the leading cause, is the most important cause of sudden death in adults, but also in this age group, in 12, 35 years, is an important cause of death. You can see here that the risk to die suddenly in young competitive athletes due to atherosclerotic coronary artery disease is also significant, 2.6 greater risk to die suddenly when practicing competitive sport activity. We know that the classic mode to death in patients with coronary atherosclerosis, atherosclerotic coronary artery disease, is the occurrence of an occlusive thrombosis, a complicated plaque that interrupt the blood flow to the myocardium, and you died due to ventricular fibrillation before a myocardial infarction develops. So, in other words, probably the most important cause is arrhythmic cardiac arrest precipitated by acute myocardial ischemia. In those patients who died according to this mechanism, you don't find evidence of myocardial infarction at postmortem. You just find, hyperacute sign of myocardial ischemia. But you also can die due to ventricular arrhythmias arising from a post-myocardial infarction scar, the so-called scar-related arrhythmias. Look at this case. Was sudden death victims during a marathon. You can see here that this particular sudden death victim showed obstructive atherosclerotic coronary artery disease of both the left anterior descending branch and the right coronary arteries without thrombosis. But look at the tributary myocardium. You can see here post-MI fibrosis that probably was the substrate for arrhythmias that were precipitated by catecholamines. We also published years ago a series of sudden death victims occurring in young people due to atherosclerosis and premature coronary atherosclerosis. We point out on the finding that in a sizable proportion of young individuals, we found premature coronary atherosclerosis in the proximal tract of the left anterior descending coronary artery, and this the plaque responsible of sudden death was a different plaque, was a fibrocellular plaque. This kind of plaque is also known as accelerated atherosclerosis. And you can't see here any kind of complication, thrombotic complication. These young individuals below the age of 35 years probably died due to a vasospasm. We advanced the hypothesis that this plaque can underlie vasospasm because these smooth cells are associated, can make the coronary segment more hypervasoreactivity. Look at the close-up of the composition, the histologic composition of the plaque. Is a fibrocellular plaque. Typical of this is a growing plaque, an accelerated atherosclerosis that can be associated with the hypervascular activity of the coronary artery. And unfortunately, this single vessel disease in these young individuals is undetectable by basal 12 ECG, but also by exercise testing. The sensitivity of exercise testing for this single vessel disease is very low, unfortunately. It's another example. This is a 19-year-old basket player dying suddenly due to premature coronary atherosclerosis. Also in this particular case, no evidence of thrombosis. You can see that the tonica media is perfectly preserved. So there is a problem. How sensitive is calcium score for this kind of plaque that is characterized by, that's completely different in terms of histologic composition. Also in this particular case, all these sudden death victims had before studied by exercise testing that was unremarkable. No ST segment changes, no arrhythmias. So another important cause non-inherited cause of sudden death are congenital coronary anomalies in this age group. Look at the risk, 79 in athletes compared with non-athletes. In other words, you die suddenly due to this condition almost during effort if you practice competitive sport activity. We deal specifically with anomalies origin of coronary arteries from the wrong coronary sinus. This is a typical example of the origin of the left coronary artery from the right coronary sinus. Both ostia originate from the same coronary sinus. And you can see here that the left coronary artery reaching the atrioventricular sulcus runs into the media of the aorta. In other words, look at the vessel is in through the media of the aorta, and of course is susceptible to be compressed during effort and create myocardial ischemia, effort-induced myocardial ischemia. So also this kind of coronary anomaly is not detectable by exercise testing, is rarely detectable by exercise testing. In this particular case, exercise testing was negative. So you can see here that the reported prevalence of coronary anomalies as a cause of sudden death in the different cities reported in the literature ranges from 4 to 24%. So it's an important, significant cause of death in this age range. The pathophysiology, there are a number of proposed mechanisms responsible for transient myocardial ischemia and arrhythmia-related ischemia-related arrhythmias that include the acute angle takeoff, the squeezing on effort, the intramyocardial aortic course of the vessel, the vasospasm, and also the fibrous scar that is the result of a cumulative damage of the myocardium, tributary myocardium. So an important point I think merits to be considered is that actually this kind of condition is rarely associated with the 12-lead ECG abnormalities. But we can find an abnormal ECG roughly in 40% of cases. What is important is that the majority of those who died suddenly due to this condition actually had symptoms before dying. So syncope, 60%, and chest pain, 33%. Syncope mostly due effort. So extremely important in young individuals with syncope or chest pain during effort. There is no reason they have this kind of symptoms. This kind of these young individuals to evaluate to think to the possibility of an anomalous origin of coronary artery. And echo is well performed. It can be useful to identify the origin of the coronary arteries. If not definitive diagnostic, of course, we should perform an MRI or CT scan of the coronary artery. Mitral valve prolapse is a mystery. We found mitral valve prolapse in a sizable proportion of our sudden death victims. It's not the echocardiographic, as pointed out before, but is a floppy mitral valve. Is a true degenerative process of the leaflet of the mitral valve. We think that is not probably the mitral prolapse in itself the cause of death. We found that the mitral valve prolapse is associated with other myocardial pathology. For example, in some cases we found an association with right ventricular dystrophy, but more recently, even thanks to the contrast-enhanced MRI, we more often find the association between mitral valve prolapse and scar in the left ventricular wall, posteriorly or the base of the papillary muscle. So we think, and we also found a significant association between arrhythmias and the presence of scar on MRI. There are preliminary data that I think would be very significant for the future evaluation. What about myocarditis? Myocarditis is another important cause of sudden death. There is no a significant difference between athletes and non-athletes with regard to this kind of disease. And what is important to remember is that Also focal myocarditis. The presence of focal inflammatory infiltrates may be a cause, maybe a substrate enough important to degenerate, to create ventricular fibrillation and sudden death, like in these cases with focal myocarditis, suddenly due to focal myocarditis. I would like to conclude my presentation with conduction system diseases with particular reference to Wolff-Parkinson-White syndrome. This is not a genetic disorder, it's a congenital anomaly. So it's the smallest congenital anomaly. It's characterized with the presence of a muscle fiber, ordinary myocardium connecting joint, joining the atrial myocardium with the ventricular myocardium, in this particular case, in the left lateral mitral annulus. So you can see here this connection is responsible for conduction, AV conduction, away from the classic AV node-ace bundle. So you can see this is an alternative way of conduction of the impulse from the atrium to the ventricle. This is the normal AV node-ace bundle axis, and this is the accessory pathway. And everybody knows the typical ECG pattern that's characterized by short PR interval and delta wave. So with regard to the risk to die suddenly, we know that sudden death is due to ventricular fibrillation, which complicates an episode of paroxysmal AF. In other words, individuals with an accessory pathway die suddenly when occurs an episode of paroxysmal atrial fibrillation that shows a rapid ventricular response of an accessory atrioventricular pathway and precipitates ventricular fibrillation. This is an example of an 18-year-old presenting at the emergency room with a palpitation, dizziness, and weakness that had appeared suddenly at rest just about 1 year before the admission. And you can see here the arrhythmia that was recorded in the emergency room was an irregular wide QRS tachycardia at the rate of 280, 300 beats per minute that was consistent with an atrial fibrillation conducting to the ventricle over a left lateral accessory pathway. You can see here that the QRS morphology is a left bundle branch block morphology suggesting, a right bundle branch morphology suggesting a left lateral accessory pathway. What is important is that it's not dysarrhythmia the cause of death. You don't die due to pre-excited atrial fibrillation. You died when atrial fibrillation, pre-excited atrial fibrillation degenerates into VF. So this is the crucial point here. So at the time of this change of the arrhythmia, you must intervene with DC shock, otherwise the patient died. So what is our contribution to this disease, I think, is significant because we found a significant proportion of cases who die suddenly due to Wolff-Parkinson-White syndrome, with demonstration at post-mortem of the accessory pathway, the coexistence of inflammatory infiltrates in the atrial myocardium. In other words, more than 40% of our sudden death victims actually had an atrial myocarditis, not ventricular, atrial myocarditis. And this is important. You can see here an inflammatory infiltrate in the atrial myocardium of a sudden death victim due to ventricular preexcitation. And this is important because this atrial myocarditis may be the trigger for atrial fibrillation in young individuals, because usually atrial fibrillation is a disease of older individuals. But if you have an atrial myocarditis, we don't know the prevalence of atrial myocarditis in the general population. But in the presence of an accessory pathway, this focal myocarditis, atrial myocarditis, that probably in itself should be not significant, may precipitate atrial fibrillation, ventricular fibrillation, and sudden death. So active acute myocarditis may be a trigger of paroxysmal AF that can be fatal in Wolff-Parkinson-White patient. The clinical implication of this observation is that the restratification of sudden death in Wolff-Parkinson-White syndrome cannot longer feasible based on either clinical symptom or induced electrical instability. We can't wait for symptoms because we can have a predictable occurrence of atrial myocarditis that can precipitate atrial fibrillation. So systematic electrophysiologic evaluation of the anterior greater refractory period of the AV accessory pathway and transcatheter ablation of high-risk patient is warranted. Thank you for your attention.